Clinical activities for the diagnosis and management of asthma that should be taught at every opportunity. The basic definition and pathophysiology of asthma. Asthma is a complex disorder characterized by variable and recurring symptoms, airflow obstruction, bronchial hyperresponsiveness, and an underlying inflammation. The interaction of these features determines the clinical manifestations and severity of asthma and the response to treatment. The working definition of asthma is as follows. Asthma is a chronic inflammatory disorder of the airways in which many cells and cellular elements play a role, in particular mast cells, eosinophils, and neutrophils, T lymphocytes, macrophages, and epithelial cells. In susceptible individuals, this inflammation causes recurrent episodes of coughing, wheezing, breathlessness, and chest tightness. These episodes are usually associated with widespread but variable airflow obstruction that is often reversible either spontaneously or with treatment. The development of asthma appears to involve the interplay between host factors and environmental exposures that occur at a crucial time in the development of the immune system. A definitive cause of asthma has not been established. For the basic role of medications, you have quick relief and you have long-term control medications. For the quick relief medications, they are used to treat acute symptoms and exacerbations. They include anticholinergics, which inhibit muscarinic receptors and reduce intrinsic vagal tone of the airway. Ipratropium bromide provides additive benefit to short-acting beta agonists in moderate or severe exacerbations in the emergency care setting, not the hospital setting. Ipratropium bromide may be used as an alternative bronchodilator for patients who do not tolerate short-acting bronchodilators, although it has not been compared to short-acting beta adrenergics. Short-acting bronchodilators like albuterol, levalbuterol, and purbuterol are bronchodilators that relax smooth muscle. They are the treatment of choice for relief of acute symptoms and prevention of EIB. Increasing use of short-acting bronchodilator treatment or the use of short-acting bronchodilators more than 2 days a week for symptom relief generally indicates inadequate asthma control and the need for initiating or intensifying anti-inflammatory therapy. Regularly scheduled daily chronic use of short-acting bronchodilators is not recommended. You can also use systemic corticosteroids. They're not short-acting, but they are oral systemic corticosteroids are used for moderate and severe exacerbations in addition to short-acting bronchodilators to speed recovery and to prevent recurrence of exacerbations. Long-term control medications are used daily to achieve and maintain control of persistent asthma. The most effective are those that accentuate the underlying inflammation characteristic of asthma. Long-term control medications include corticosteroids, which are anti-inflammatory medications that reduce airway hyperresponsiveness, inhibit inflammatory cell migration and activation, and block late-phase reaction to allergen. Inhaled corticosteroids, or ICSs, are the most consistently effective long-term control medication at all steps of care for persistent asthma, and ICSs improve asthma control more effectively in both children and adults than leukotriene receptor antagonists or any other single long-term control medication do. ICSs reduce impairment and risk of exacerbations, but ICSs do not appear to alter the progression or underlying severity of the disease in children. Short courses of oral systemic corticosteroids are often used to gain prompt control of asthma. Oral systemic corticosteroids are used long-term, often used to gain prompt control of asthma. They're used long-term to treat patients who require step 6 care. Cromolyn sodium and metocromil stabilize mast cells and interfere with chloride channel function. They are used as an alternative but not preferred medication for patients requiring step 2 care. They also can be used to prevent treatment before exercise or unavoidable exposure to known allergens. Immunomodulators like omalizumab is a monoclonal antibody that prevents binding of IgE to the high-affinity receptors on basophils and mast cells. It's used as an adjunctive therapy for patients 12 years of age who have sensitivity to relevant allergens and who require step 5 or 6 care. Clinicians who administer this drug should be prepared and equipped to identify and treat anaphylaxis that can occur. Leukotriene modifiers interfere with the pathway of leukotriene mediators, which are released from mast cells, eosinophils, and basophils. These medications include LTRAs. LTRAs are alternative but not preferred therapy for the treatment of patients who require step 2 care. LTRAs also can be used as an adjunctive therapy with ICSs, but for youths 12 years of age and adults, they are not preferred adjunctive therapy compared to the addition of long-acting bronchodilators. LTRAs can attenuate EIB. Zoluten can be used as an alternative, but it's not preferred adjunctive therapy. In adults, liver function monitoring is essential. Long-acting bronchodilators are inhaled bronchodilators that have a duration of bronchodilation of at least 12 hours after a single dose. Long-acting bronchodilators are not to be used as monotherapy for long-term control of asthma. They should be used in combination with ICSs for long-term control and prevention of symptoms in moderate or severe persistent asthma. Of the adjunctive therapies available, long-acting bronchodilators is the preferred therapy to combine with ICSs in youths greater than 12 years of age and in adults. A long-acting bronchodilator may be used before exercise to prevent exercise-induced bronchospasm, but duration of action does not exceed 5 hours with chronic regular use. Frequent or chronic use before exercise is discouraged because this may disguise poorly controlled persistent asthma. You can also use methylxanthines, which are sustained-release theophylline. It's a mild to moderate bronchodilator used as an alternative, not preferred therapy for step 2 care, or as an adjunctive therapy with ICS in patients greater than 5 years of age. Theophylline may have mild anti-inflammatory effects. Monitoring of serum theophylline concentration is essential. Patient skills. Taking medication correctly. The optimal technique for specific patient populations. For an MDI, the population is greater than or equal to 5 years old. However, children less than 5 can use a spacer or a valved holding chamber or a mask for their MDIs. The optimal technique for this population and device is actuating during a slow, deep inhalation followed by a 10-second breath hold. Under lab conditions, you can use an open mouth technique to enhance delivery to the lung. This technique, however, has not been shown to enhance clinical benefit consistently compared to the closed mouth technique. For the breath-actuated MDI, the population is greater than or equal to 5 years old. The optimal technique for this device is to make a tight seal around the mouthpiece and take a slightly more rapid inhalation than for your standard MDI, followed by a 10-second breath hold. For the dry powder inhaler, or DPI, the population is greater than or equal to 4 years old. The optimal technique for this device is a rapid deep inhalation. It's minimally effective if your inspiratory flow is too low. Most children less than 4 years of age may not generate enough inspiratory flow to activate the inhaler. For the spacer or the valved holding chamber, the population is greater than or equal to 4 years old. However, children under 4 should use their valved holding chamber with a mask. The optimal technique for this device is a slow, deep inhalation followed by a 10-second breath hold immediately following the actuation. You actuate it only once into the chamber per inhalation. If the face mask is used, it should have a tight fit and allow 3 to 5 inhalations per actuation. You should rinse your plastic valved holding chamber once a month with low concentration of liquid household dishwashing detergent and let it drip dry. Patients of any age who cannot use an MDI with the valved holding chamber and face mask should use a nebulizer. The optimal technique for this device is to do slow tidal breathing with occasional deep breaths. Tightly fitting face mask for those unable to use the mouthpiece. Using the blow-by technique is not appropriate. Therapeutic issues. For the DPI, the dose is lost if the patient exhales through the device after actuating. The delivery may be greater or lesser than an MDI, depending on device and technique. Delivery is more flow dependent in devices with highest internal resistance. Rapid inhalation promotes greater deposition in larger central airways. Mouthwashing and spitting is effective in reducing the amount of drug swallowed and absorbed. MDI with or without the spacer or holding chamber. Slow inhalation and coordination of actuation during inhalation may be difficult, particularly in young children and the elderly. Patients may incorrectly stop inhalation at actuation. The deposition of 50 to 80% of actuated dose is just in the mouth. Mouthwashing and spitting is effective in reducing the amount of drug swallowed and absorbed systemically. Lung delivery under ideal conditions varies significantly between the MDIs due to differences in formulation, propellant, um, and valve design. For example, inhaled corticosteroid delivery varies from 5 to 50%. For the breath-actuated MDI, it may be particularly useful for patients unable to coordinate inhalation and actuation. It may also be useful for elderly patients. Patients may incorrectly stop inhalation at actuation. It cannot be used with currently available spacer or valve holding chamber devices. For the small volume nebulizer with a mask or mouthpiece, it's less dependent on patients' coordination and cooperation, the delivery method of choice for cromolyn sodium in young children. It may be expensive, time-consuming, bulky. The output is dependent on the device and operating parameters. Internebulizers and internebulizer output variances are significant. Use of a face mask reduces delivery to the lungs by 50%. Nebulizers are as effective as MDIs plus the valve holding chamber for delivery of bronchodilators in the ER for mild to moderate exacerbations. Data in severe exacerbations are limited. The choice of delivery system is dependent on resources, availability, and clinical judgment of the clinician caring for the patient. Potential for bacterial infections if not cleaned properly. For identifying and avoiding environmental exposures, you need to find out what makes your asthma worse. Some things that make asthma worse for some people are not a problem for others. So you might not need to do all the things that I list next. If you smoke, you should ask your doctor for ways to help you quit. You should ask family members to quit smoking also. Don't allow smoking in your home, car, or around you. Be sure no one smokes at your child's daycare center or school. Many people who have asthma are allergic to dust mites. They're tiny bugs you can't see that live in cloth or carpet. Things that might help with this problem are to encase your mattress in a special dust mite proof cover, to encase your pillow in a special dust mite proof cover, or to wash the pillow each week in hot water. The water has to be hotter than 130 degrees Fahrenheit to kill the bugs. Cooler water used with detergent and bleach can also be effective. Wash the sheets and blankets on your bed each week in hot water. Other things that can help can be to reduce indoor humidity to or below 60%. Ideally, it should be 30 to 50%. Dehumidifiers or central air conditioners can do this. Try not to sleep or lie on cloth-covered cushions or furniture. You should remove the carpets from your bedroom and those laid on concrete if you can. You should keep your stuffed toys out of the bed or wash the toys weekly in hot water or in cooler water with detergent and bleach. Placing toys weekly in a dryer or freezer might help. Prolonging exposure to dry heat or freezing can kill mites but does not remove the allergen. Some people are also allergic to the flakes of skin or dried saliva from animals. The best thing to do is to keep your pets with fur or hair out of your home. If you can't keep the pet outdoors, then keep the pet out of your bedroom and keep the bedroom door closed. You should remove the carpets and furniture covered with cloth from your home. If that's not possible, you should keep the pet out of the rooms where these are. Many people with asthma are allergic to the dried droppings and remains of cockroaches. So to avoid that, you should keep all food out of your bedroom. You should keep food and garbage in closed containers. You should use poison baits, powders, gels, or paste. You can also use traps. If a spray is used to kill the roaches, you need to stay out of the room until the odor goes away. Try to get someone else to vacuum for you once or twice a week if you can. Stay out of rooms while they are being vacuumed and for a short while afterwards. If you vacuum, you should use a dust mask, a central cleaner with the collecting bag outside the home, or a vacuum cleaner with a HEPA filter or a double-layered bag. You need to fix leaking faucets, pipes, or other sources of water and clean moldy surfaces because these can also accentuate your symptoms. Dehumidify your basements if you can during your allergy season. You might try to keep your windows closed. If possible, you need to stay inside with the windows closed during midday and afternoon. Pollen and some mold spore counts are highest at this time. Ask your doctor whether you need to take or increase your anti-inflammatory medicine before your allergy season starts. If possible, don't use a wood-burning stove, kerosene heater, fireplace, unvented gas stove, or a heater. Try to stay away from strong odors and sprays such as perfume, talcum powder, hairspray, paints, new carpet, or particle board. You should be able to be active without your symptoms. See your doctor if you have asthma symptoms when you are active, such as when you exercise, do sports, play, or work hard. Ask your doctor about taking medicine before you exercise to prevent those symptoms. It helps if you warm up for a period before you exercise. It's important to check the air quality index and try not to work or play hard outside when the air pollution or pollen levels are high. Other things you can do, don't drink beer or wine or eat shrimp, dried fruit, or processed potatoes if they cause your asthma symptoms. It helps if you cover your nose and mouth with a scarf on cold or windy days. You should tell your doctor about all medicines you take, including cold medicines, aspirin, and even eye drops. For self-monitoring, you want to assess your level of asthma control, monitor your symptoms, and if prescribed, do your peak expiratory flow measurement. This will help you recognize early signs and symptoms of worsening asthma. Lastly, you want to develop and review an action plan. Using a written action plan to know when and how to take daily actions and to control asthma. It helps you adjust your medication in response to your signs of worsening asthma. This is an example of an asthma action plan for an adult. You just go through here and fill out your name, your medical record, your date of birth, your doctor's name. You list your long-term medications, how much you take, how often you take. It also has a chart for how you're feeling when your peak flow is in the green zone, when your peak flow is in the yellow zone, and when your peak flow is in the red zone. And it tells you what to do if each of those things happens. There's also action plans for children, which look very similar. They may give you different tips since you are a child.